The number one symptom that I hear from my patients the most is, I don't feel like myself anymore. And this is usually in those early 40s to mid 40s.
Is there a way to look at maybe hormone levels or Dutch testing or even just markers of metabolic health that might be off? Like, are you looking for any objective measurement of early perimenopause? Is there something like that?
Symptoms, age, and tracking your menstrual cycle.
Got it.
That monthly report card can give me so much information and give you so much information. Most importantly, track your symptoms around your cycle. So do you feel amazing in that follicular phase, but then 5 days into the luteal phase, something shifts instead of it being only 3 days before your period? So those are the types of things I'm looking at. If I can get a timeline of those labs so I understand your baseline and your normals, I want to get that as early as your 30s so that I know what is your normal fasting blood glucose? What is your normal fasting insulin? What's your normal CRP, your highly sensitive CRP? What is your normal triglyceride to HDL ratio? I want to know those numbers going in.
Dr. Snyder, thank you so much for joining me on Extend.
Dr. Shah, it's so good to be here.
Yeah, this is so amazing that we were introduced by so many people and they're like, you have to have her on. And now that I get to know you a little bit more and your book, like I'm so excited to dive into this with you.
Yeah, thank you for letting me just spread the word about this profound transition. And I love your platform. I love what you're doing. I love that you are transforming health.
Thank you so much. You know, when we started this podcast, we said that half the guests have to be women because there's so much that's not talked about for women. And I think perimenopause is definitely the one topic that women, until just recently, like literally the last few years, have been told not to talk about.
Yeah, no, it's been very much an area of dismissal for women.
Right.
And women just thinking, okay, well, maybe it is just stress, or I'm being a mom, or maybe I'm just making it up. You know, so many of the symptoms of perimenopause are subjective. And when it comes to women's health, often when we come in with subjective symptoms, we aren't connecting the dots between those symptoms and it being perimenopause. In fact, in the U.S. alone, it takes between 4 and 6 office visits for your primary doctor or even your OBGYN to connect the dots between your symptoms and it being perimenopause.
That's just mind-blowing to me because it's not like perimenopause just started happening 10 years ago.
No.
This has been going on since the beginning of humanity.
It's an inevitability.
Right.
If you live long enough, yes, it's going to happen.
I mean, and do you think some of that is a combination of maybe, you know, women were traditionally, you know, taught to suffer in silence with this, combined with our medical system just, you know, there's no silo for perimenopause, right? There's no silo for hormone health in Western medicine. It's either endocrinology, which is like a hormone like a disease of the hormone system, or it's just a bunch of different silos based on the system that is being affected. Like if you have headaches, you go see a neurologist. If you have gut issues, you go see a GI doctor. Why do you think it's been so ignored?
That is such a good question. I would say that we were paying attention to menopause. We kind of knew what menopause was, mainly because we had medications for menopause. So we're like, oh, hot flashes, night sweats, maybe some sleep issues, vaginal dryness, low libido. Okay, here's Premarin.
So we had a medication for the symptoms.
Yeah,
of
for the
those.
symptoms.
Yeah.
And we kind of knew, you know, kind of when women go through menopause, it's that one day in time where they haven't had a period for 12 months and you're in menopause. And then we had a medication or a solution for menopause symptoms to manage those symptoms. But we didn't have anything for perimenopause. And here's the thing is that perimenopause into menopause is really a continuum. There's no you go from one and then you reset to the other, right? You just keep going. And I call it the silent shift because a lot of the changes that happen in perimenopause are your blood pressure is creeping up. Your blood glucose levels are going up. You are losing muscle mass. You're losing bone mass. And we don't feel these things. And so we didn't really have a quote unquote, you know, medication or solution for this profound transition where women are coming out of their childbearing years into menopause and postmenopause.
Yeah, that makes total sense. And to your point, like, you know, your sugar goes up, your blood pressure goes up. Now you're being given medications for hypertension. You're giving medications for hyperglycemia, but you're not really getting to the root of the problem.
No, you're not getting to the root of the problem.
Yeah, and I think that's part of the issue. And what about this kind of societal imperative to just not really talk about it.
Yeah, I think two things are happening here that you had mentioned earlier, that we just suffer through it. That is, and you go to your doctor's office, one of the doctors I was just interviewing, that's a dear friend of mine, we were talking about the end of her perimenopausal journey. And she said what was the most destabilizing for her journey was the brain-related symptoms. And 80% of perimenopausal symptoms are brain-related. Brain fog, lack of word recall, sleep issues, even hot flashes and night sweats are brain-related symptoms.
So 80%.
80%. Irritability is the most common symptom. Mood swings, rage, depression, anxiety, these can all be triggered by erratic declining hormones in perimenopause. So she goes to her doctor. She's in late peri. She's not able to think properly. Her brain, this is a high-functioning doctor for many, many years, 30 years in practice. And all of a sudden, she even wonders, am I going to be able to finish this book? And her sleep was so just messed up. She wasn't able to get to sleep. She was waking up at 3 o'clock in the morning. So she goes to her doctor, and her doctor is on sabbatical. So she gets another doctor who's in her 60s. And basically, she's like, listen, she wanted hormones. She's like, this isn't indicated for hormones. When it comes to sleep, I don't have anything for you. And you just need to suffer through it. Like, that's what I've been doing. I'm suffering through it. You can suffer through it. I've got these cheats that you can implement that can help you a little bit, but like, I'm not prescribing hormones for you. And I asked her, I was like, how did it feel to be one of your patients who have had that experience and then have come to you because of that dismissal?
Right.
How did it feel to have to really advocate for your health when this is what you have been doing for 30 years? And, she was like, it was really wonderful to be able to have that experience, to know what my patients felt when they were getting dismissed, when they walked away with more questions than answered. But more importantly, she's like, it was really disheartening to know that I was going to have to keep going to bat for myself. And finding someone who was finally going to prescribe a solution for me that I knew that was going to be effective.
Oh, so sad. I'm sure that is pretty much the rule rather than the exception still, right? Yeah.
Yeah, I think women have been told to just blame ourselves.
Yeah.
It's your fault that you are gaining weight. It's your fault that your brain isn't working. It's your fault that you can't show up to work the way that you used to. And so what I think ultimately happens is that women, what we do best is we overextend, we over-effort, we over-try. And that can lead to a lot more burnout and a lot more symptoms. It feels so, again, disheartening, and it can feel like you're losing hope about what you can do for your body. And we know that when we're in that state of hopelessness or that things are feeling insurmountable, that it tends to exacerbate symptoms as well. So we kind of end up in this like a roller coaster of symptoms, kind of driven by not getting the care that we deserve.
Sure. Does perimenopause sneak up on women? Does it hit them like really hard, or is it a spectrum in between?
I love this question. This is actually why I wrote the book, The Perimenopause Revolution, because there's no one day where perimenopause announces itself. Right? It's like, I'm here. Or there's no one test, right? There's no one test that's going to, if anything, because how we define perimenopause is this erratic decline in hormones. One day they're going to be up, the next they could be down. So I could catch you on a good day when I'm running labs and everything looks good. And let's be honest, those reference ranges for estradiol and progesterone are pretty wide, are pretty big. And so we can easily tell women it's normal. I would say that when you're stepping into early perimenopause, a lot of the symptoms are very subtle. What women will tell me is they will notice that they don't have as much bandwidth as they used to have. Like before, maybe even a year prior, they could handle the household, the career, the family, all of the to-do list and do it effortlessly. And they could multitask like ninjas. And then all of a sudden, they're having to try harder. They're having to effort harder. They'll also notice that closer to their cycle, they're feeling more irritable, maybe day 5 and day 4 versus it was only day 2, maybe 3 days. So their PMS symptoms begin to extend. They're noticing cyclical changes, but more so brain-related. Their stress resilience isn't what it is. They feel more irritable. Maybe they're noticing their workout recovery isn't the same. And body composition changes are beginning to happen, but more so, again, it's brain-related. And then by the time we're in early peri, I would say for my patients, 42, 43, Show me a sign, make it impossible for me to miss. This is where women really notice the mood changes, really notice the brain changes, the brain fog. I always say I catch women perimenopause in the wild, where I'll have a friend who's like trying to remember the word and they don't know what the word is. Even my son, who's almost 5, I'll say, the thing over there. And he'll be like, the Lego? And so he completes my sentences all the time. Or I'll walk into a room like with intention and not know why I walked in there once I get there.
Yeah.
Like that is what women will start to notice. And they'll be like, this is not normal. The number one symptom that I hear from my patients the most is, I don't feel like myself anymore. And this is usually in those early 40s to mid 40s. Cycle changes, regular cycles are typically still happening at this point, but women will notice maybe a shorter cycle or a heavier bleed or lighter bleed. So they'll notice cycle changes if they're paying attention, but again, nothing overt and obvious. But then when we get into late perimenopause, and this is where I feel like the medical system was like, this is perimenopause. This is where we are missing periods up to 60 days.
Yeah.
And that's
now
when we're like,
definition.
this is perimenopause, this is late. But now we know that women have been suffering or struggling with more brain-related symptoms or even more subtle symptoms for maybe 3 to 5 years prior till they get to that point where they're finally skipping periods.
Yeah.
And that's where I see the hot flashes, the night sweats, the low libido, the vaginal changes. That's really in the late perimenopause because now we're in a low estrogen state.
Got it. So in the early perimenopause time, some of the symptoms you mentioned, like I just can't multitask as much, or I'm struggling to get through more things, they're kind of hard to pinpoint for women. I think there's like a struggle period there, right? And so, I think about my own wife, like that time period, it's kind of like, what's going on, And I wish there was some biomarker or blood test that you could say, this is what's happening. And so is there a way to look at maybe hormone levels or Dutch testing or even just markers of metabolic health that might be off? Like, are you looking for any objective measurement of early perimenopause? Is there something like that?
I am.
Yeah.
But it is a lot of subjective. Like a clinical diagnosis is often based on symptoms. So 3 things that I'm looking at. One, I'm looking at your age. If you are 41, 40 years old or 42 and you're like, I don't feel like myself and the symptoms are adding up, I'm going to call it's perimenopause. And it could be other things as well. It could also be stress.
Yeah.
It could also be, low thyroid function. It could be a number of things. I would say a lot of women come into perimenopause, with some other health concerns. Maybe they've had polycystic ovarian syndrome for most of their life. And so that's very much a viable, kind of factor going in. Maybe they had children late. Maybe they were like me and had a little boy at 41 years old, in our postpartum until they get into perimenopause. So all of these need to be taken into consideration. So I say symptoms, age, and tracking your menstrual cycle.
Got it.
That monthly report card can give me so much information and give you so much information. Most importantly, track your symptoms around your cycle. So do you feel amazing in that follicular phase, but then, 5 days into the luteal phase, something shifts? Instead of it being only 3 days into, 3 days before your period. So those are the types of things I'm looking out for. In terms of looking at biomarkers, I do want to look at everything. And ideally, if I can get a timeline of those labs so I understand your baseline and your normals, I want to get that as early as your 30s so that I know what is your normal fasting blood glucose? What is your normal fasting insulin? What's your normal CRP, your highly sensitive CRP? What is your normal triglyceride to HDL ratio? I want to know those numbers going in. Like, what is the state of your metabolic health and your cellular energy? Is that going to start to shift in perimenopause? And what I will notice is women who are very, very early peri, things still look pretty good. Their, metabolic markers are good. They're still metabolically healthy. But as we move through that perimenopause transition, that's when I see things beginning to shift. So I will see more insulin resistance. I will see blood pressure starting to climb. I will notice that their lipid markers are going into an unfavorable range. I will also notice vitamin D levels begin to drop. Thyroid panels begin to go into unfavorable range. And so the more data I can have on you heading into perimenopause, the more that I can begin to see those changes. And they can even still be subtle.
Yeah.
So that's what I would be looking at as they enter perimenopause.
Yeah, we're huge advocates of, regular biomarker testing here. So we do what's called a baseline in Next Health, and we do that every 3 to 4 months on all of our patients, men and women. And it can show early perimenopause happening just by fasting insulin going up, like you're saying, and it's more than just the hormone levels. It's also other markers that even inflammation sometimes can go up
Absolutely.
in perimenopause too, right? So I think it's super important to be really more proactive about checking biomarkers and also having someone like yourself that can review them with you as well.
Yeah, we live in a world of bioobservability that we can know so much about our bodies. And women were first the first biohackers, I believe, because we really had to know our cycles to understand ovulation. I always say that ovulation is the main event, right? We can't have progesterone on the back end in the luteal phase if we don't have good ovulatory cycles. And so that kind of information alone, if you're feeling flat in that luteal phase, if you're noticing your PMS symptoms are more severe, it could be that you're having anovulatory cycles at this point, and that progesterone just didn't show up in that cycle. And as a result, you're noticing those changes. Also, I do love looking at hormones. I like looking at, like I said, a full thyroid panel. I also want to look for anemia. Especially in perimenopause. Is that contributing to her fatigue and her burnout? And I want to look at testosterone, estradiol, cortisol, melatonin, and progesterone. And again, it's about reading the tea leaves, I find, when it comes to those levels. But when I have a comprehensive look at everything, I can really start to put the pieces together.
Yeah, it makes total sense. And how are you looking at cortisol? Is that being looked at, are you using the 4 times a day salivary testing?
Ideally. Yeah. Let's say if I can't get that salivary testing, I will at least look at the AM cortisol. Right. Yeah. But ideally, I would love to look at that salivary testing because majority of women in perimenopause, including myself, have had deregulated cortisol levels moving into that phase, especially if you didn't realize what was happening.
Right. I think also, like you mentioned earlier, it's so helpful to have the early biomarkers as well, so you have something to compare to, right? So maybe you're not in perimenopause yet, or maybe you're even 35 years old or 30, and still it's worth having a set of biomarkers done so you know what your normal is prior to going through this.
Absolutely. I think that type of information, knowing your normals, it allows you to advocate more thoroughly, more effectively for your health.
Yes.
And I think that's so important.
Yeah, you can bring that to your doctor and be like, look, this is not normal for me. This is where my normal is. What's going on? I think that's really powerful to have that data.
Yeah, I have my lab data and I have a timeline. I actually have an Excel spreadsheet of my labs that I track. And I track my symptoms. You know, when I tell my patients if they're going into their primary or their OBGYN or seeing someone else, what they're doing is treat that meeting like it's one of the most important meetings that you have, that you are advocating for yourself. Bring it on paper. So have your labs on paper, have your most disruptive symptoms on paper, connect them to how it's impacting your life. I feel like doctors can really move the needle for you in a meaningful way when they can see how it's impacting your lifestyle and your quality of life. And then I also recommend knowing the labs that you want to run, you know, and I talk about this in the book. I've got so many guides where this is a reference ranges, functional reference ranges, but I want you to take this list. Just cut this paper out and take this list to your doctor and advocate for these labs. And then I also recommend if you're having a hard time getting what you want or saying what you need, you bring someone else with you who can really help support that. Because that's going to really move the needle in you getting the care that you deserve and the support that you deserve. And it's also worth asking your doctor, do you take care of women in perimenopause and menopause? Do you deliver perimenopause and menopause care? And, you know, what are some of the solutions that you offer? I think it's a worthy conversation. By the time we're in peri, we're about halfway through life. And so I think that it becomes really important for us to get clear on what matters to us. And at the epicenter of that is feeling revitalized, feeling energized. And if you don't have a good team working with you to get that done, you're just not going to feel your very best in that second part of your life.
Yeah. And to your point, many doctors do not treat perimenopause. Even OBGYNs sometimes don't treat perimenopause. They don't really feel there's an indication for treating it, so they don't treat it. Is that correct?
Yeah, absolutely. And I mean, OBGYNs, it's really a surgical residency if you think about it. I mean, thank goodness they're here delivering our beautiful boys and girls to us. Thank goodness they're catching things and supporting, you know, surgical interventions with endometriosis and fibroids. And so you think about a lot of it is a surgical residency. I think on average, only right now in terms of for OBGYNs, 30% of OBGYNs get any type of menopause and perimenopause care.
Only 30%.
And that's changed in the last 5 years. 5 years ago, it was only 20%. So it has jumped 10% in the last 5 years. But if you ask, a lot of residents do not feel equipped to treat women in perimenopause and menopause currently today.
But it's so disempowering to like think, okay, I'm having these symptoms. I'm going to talk to my OBGYN about it. I can imagine as, being a woman, like thinking you're going to the doctor, they're going to help you with this, and they don't even evaluate it or treat it. And then it's like, what do you do then, And like to your point, it's amazing. You could give them a set of labs you want them to run, but they still probably won't
they're not going to interpret
it.
them. Yeah.
Right.
They're going to be within normal range or, they're, unless it's in that red zone, we're pathology driven in the healthcare system. It's very reactive.
Right.
And so we're often not going to get to the root cause of what is going on.
Right.
And that's when I think it's important to ask that question. And I know that I have an amazing OBGYN. I know how far I can go with her. And I know what she's going to be able to provide and what she's not going to provide. And so I'm not disillusioned by the experience.
Right.
And I know that if I'm looking for someone who's going to really support me in this perimenopause and menopause journey, looking at connecting the dots between my symptoms today and my health outcomes later, or just looking into my future health and how this is going to play out for me in terms of longevity and health span, I know that I'm going to need someone who has a much more functional perspective.
Yeah. And I think this all goes to every woman and man. You need to become the CEO of your own health. You need to take control of your healthcare journey and not outsource it to the Western medical system, because no one's going to care more about your own health than you do, right?
And no one's going to know it.
Exactly. No one's going to know it. They're not going to be advocating for themselves. They're not going to be following it. And I think there's this mindset that I grew up with, even being a doctor.
Me too.
That, right?
Yeah.
You grow up and you're like, your doctor will just take care of it.
Yes.
And if they say nothing's wrong, and don't pursue it, and don't even ask any questions, right? And so I think so many people have been done a disservice there with just that mindset. And I think we're entering a new era where people are becoming more curious about their own health. They're checking their own biomarkers. They're, advocating for themselves by reading books like yours and really going that extra mile to push for their own health. And I think everyone needs to do that. It's so important.
Yeah, I think each and every one, all of us have family members.
Yeah.
I have a sister who had a stroke 2 years ago. She's 2 years younger than me. I have uncles that have had bypasses, family members with prediabetes. I mean, we see this in our families, and we see that it's not even that far down the road.
Your sister had a stroke and she's 2 years younger than you. Wow. Was it from a blockage or was it from something else?
Lifestyle, unfortunately.
Yeah.
And so it was a wake-up call for all of us. And I was first to the scene to take care of her, help her manage her care when she was going through it. I called all of my cardiology friends who are more longevity doctors about what we could do, because I knew that the hospital could only do so much for her. Yeah. I mean, the way that we've been treating strokes, it's been the same for almost 20 years.
Yeah.
And so, I wanted to know what else could we do for her.
Yeah.
And that was just a big moment for me, where I have my younger sister is going through something I didn't imagine she would. Well, I never hoped she'd have anything like that happen to her, but I at least thought she had another 20, 30 plus years before that was indicated. And we all have family members where we are supporting them in the journey. We've got maybe aging parents. We're in that sandwich generation, and we are seeing what is happening to our family, and it's not the path that we want for ourselves. Right. And when we reverse engineer, when we started to see those subtle symptoms, for a lot of our parents or our aunts or uncles or maybe siblings, maybe it was in their 50s. Maybe it was in their early 60s. My mother is such an example of how to thrive. She's 64 years old. She'll be running a half marathon next weekend.
Wow.
She's training for another marathon in Loma Linda. She lives right outside of Loma Linda, one of the blue zone areas.
Loma Linda's a blue zone, right?
Yeah, and she's a competitive tennis player. And she could shot put my son into the air if she wanted to. Wow. She can run with him. She can get on the floor with him. And I have another one of my best friends. She has a little boy, almost my son's age. And her mama, same age as my mom, actually maybe a year younger, and doesn't feel confident to be left alone with him because she can't get on the floor with him. She's not able to do the things. And you look at that path.
Yeah.
When the subtle symptoms for my best friend's mother started to show up probably in her 40s, maybe even in her 50s. And now here we are at early 60s, really struggling with her quality of life.
And why can't she do that? Like what's going on?
Cardiovascular disease, prediabetes, chronic pain, rheumatoid arthritis, but a mismanagement of care.
It's a total constellation of diseases that, we have names for each one of the diseases, but they're all one thing.
It's all cardiometabolic health.
Exactly. It's all cardiometabolic health. And it affects your immune system. That's why you get autoimmune disease. And I resonate with this because that's what happened to me 10 years ago. I had cardiometabolic disease. I had diabetes. I had an autoimmune condition. I had all of this. And it was all really part of one process that was occurring. And I was being treated by 5 different doctors with 10 different medications, right?
And not getting better.
And not getting better. And then I discovered functional medicine and found out what the root cause was, fixed it. Everything went away.
Yeah,
right?
That's incredible.
And it's such an important point that we feel that these are just little things that happen along the journey of life and health. But the reality is it's not little things that are happening along the way that need to be treated with a different prescription. There's root causes to all of this that can be fixed and you can eliminate it.
Absolutely. No, there are root causes. And I think about the quality of life that my mother has versus the quality of life that my best friend's mother has. And it is the disparity is so different. Great. Yeah. And I'm choosing my mother. Yeah. I'm choosing that direction.
Absolutely.
Yes. And so, we get to feel phenomenal in our 60s. My mom doesn't take any medications. Her blood glucose levels, she is a part of the 7% that is metabolically healthy.
Yeah.
I just looked at her labs 2 weeks ago and I was like, high five, Mom. Like, do you know how many 64-year-olds are metabolically healthy?
I know.
A very small percentage, right? It's like 1%. And I was celebrating her so big.
Amazing.
Because she shows up for her, but she is the epicenter of her family. And she is such an example of what it can look like when we really prioritize ourselves.
Yeah. And, you talk longevity. Like, I would say even though your friend's mom and your mom are the same age, your mom has already lived an extra 10 years, right? Because she's been healthy the last 10 years.
Right.
Your friend's mom hasn't.
No.
She hasn't been picking up kids and all these things. Longevity is really putting those years back in.
Absolutely.
To the years you're living right now.
Well, and I think a lot of, we think about heart disease as a man's disease, but more women than men die of heart disease and stroke. Also, women spend, although we live longer, I think for women it's like 81 years on average, and men it's like 76 to 78, but we live longer, and yet 20% more of our lives are spent in debilitating health. What's important to note about that, one, it is every time I hear that stat, every time I share that, I am heartbroken because I know how much these women have given to their communities, to their families, to everyone around them. I was brought up being self-sacrificing, and how much, and then all of a sudden it's time to take care of us and we're already struggling. Right. And that moment, that transition of perimenopause is really the window of vulnerability, but also the window of opportunity. It is not in our 60s and our 50s where we want to really be making these changes, although now is the new later, always. But it's in this transition where we're starting to notice these symptoms. These symptoms are signals. They're telling our body that we need a new level of support and care. And I think the more that not only the medical system begins to pay attention to this, but mostly us as women, as we're navigating this transition in probably one of the busiest seasons of our lives, I want to I recognize that.
Yeah.
But when we start to notice these symptoms, the brain fog, the moodiness, the weight resistance, the body composition changes, the just not feeling like ourselves. I don't want women to wait until menopause or postmenopause. I want you to act now because in this window of opportunity, there is so much that we can do to future-proof our health.
Yeah, so true. And, you said women give so much of themselves to raise kids and manage busy families and all of this stuff. And then when perimenopause comes, it's usually, I think for some women, it's still a really busy part of their life, right? Like
I feel that.
I think our kids are 11 and 7 and it's so busy. And right now my wife's going through perimenopause and it's like, the busyness doesn't stop right now, right?
No.
But there needs to be kind of the shift in mindset to some level of self-care, like what you're saying.
Absolutely. I was being interviewed earlier, and I was walking someone through my morning routine. My son, he's almost 5. Yeah. He's going to farm camp, and he wants to see mama the first moment he wakes up. And so I know that I have a window before my son wakes up, and I am fully in the morning routine of his routine.
Yes.
And so this morning I got up at 6 a.m. I did my 30-minute weight training, and I did it from the house today because I didn't want to leave the house. I wanted him to see me when I woke up. I did my electrolyte water. I did my green juice. I really took care of me. I grounded outside in my backyard, and I just took a moment to be with me. I had my water, my coffee, and then I heard the little steps. I heard those little steps coming down the stairs. But I got that 45 minutes to attune to me, take care of me before my whole morning became his.
Yeah.
And I think those are the things that really move the needle. Like, how do we bookend our days, the nighttime and the morning, that are for us? If the day is going to happen to you, I always say that perimenopause is the messy middle. But then your day is the messy middle in the messy middle, right? Where anything can happen. What's really sacred is that bookend, where you can honor your sleep routine, you can honor your morning routine to set yourself up for success. And that's what I do. Like, I'm in a car for 6 hours today, give or take, and I'm getting squats in everywhere I can, and I'm moving my body, but I make sure that I anchor into those routines.
That's so powerful, because I think it's so funny. The last podcast I just did, we just talked about this, is you get that morning routine in, you've made a major win for the day. And it's also, I think, mentally beneficial to have the win time for yourself, because no matter what happens in that messy middle, you at least know that you had a win in the morning for yourself. You feel good about, you got your workout in, you got your me time in for a little while, 45 minutes.
I mean, I'll take it any day of the week.
I love it. So, okay, say you're a woman listening to this podcast and you're saying, I think I might be in perimenopause. I'm 39, 40 years old. I do have headaches every once in a while. I have, I feel sluggish. What should I do besides of course, reading your book?
Obviously reading the book.
And then talking to your doctor. But what are some of the things that you can do to start managing this time of your life?
I would say number one, really collecting that data, whether it is, tracking your cycle, tracking your symptoms, understanding what's going on, maybe even getting a continuous glucose monitor to track your blood glucose to see if that's the energy issue, or even a Whoop. I love looking at my body score. I love looking at my HRV, my heart rate variability, just understanding my biometrics over the course of 24 hours and over the course of a month. So just collecting data on yourself, being the objective observer of what is going on. But then I would start by looking at your day. How does your morning look? Is it controlled chaos in the morning? One of my favorite quotes by Louise Hay is, how you live your day is how you start your morning is how you live your day, and how you live your day is how you live your life. And that was such a defining moment for me, because there was a time where my morning was chaos. And then was I surprised that the rest of my day looked just like my morning? And so taking a look and seeing what are some subtle things that we can do. I always tell women, start with balancing your blood sugar. That's probably one of the biggest things we can do. And that's with meals. So prioritizing protein and fiber and healthy fats, doing your best to eliminate the refined grains, the added sugar, the ultra-processed foods as best as possible, and then moving as much as possible throughout your day. Yes, it's good that I got the 30-minute weight training workout in today, but I know that if I'm going to sit for 6 hours today, that it's going to pretty much negate the 30-minute workout. So I want women to be moving their body as much as possible. The 10 squats after a meeting, or even the 20 squats after a meeting, walking up and down your stairs after a podcast. I did a 60 squat buy-in into this podcast.
Amazing.
I was behind that pillar and I did 60 squats.
Oh, you're amazing.
I call it the 60. Well, it's usually when I'm in my Nikes, when I'm in my workout clothes, it's jump squats. But when I'm in a little dress and some heels, it's squats. And so I did my 60 squat buy-in, and I'm going to do another 60 squats before I get in the car.
That's a great idea.
And so I have 3 minutes. I always have 3 minutes to knock out 60 squats or 60 jump squats. Then the next thing I would tell my beautiful patient is to prioritize your sleep like it is $1 million meeting, because it is. So whether that is having a good sleep routine or nailing your sleep consistency. So I think that sleep consistency is probably one of the most powerful things that you can do to support your circadian rhythm, support your mitochondria, and support your sleep. And so I always benchmark, try to be in bed by 10 and be up between 6 and 7, like whatever that sleep consistency is for you. But this is 7 days a week.
Yeah.
There's no social jet lag here. We want to make sure that that's consistent. And then, having a routine that supports that. Gone are the days where we can just race into bed and fall asleep. Like, we really got to set that. No, it doesn't happen. Like, oh gosh, where did the 20s and my 30s go?
Yeah.
And so being really intentional about that routine in the evening. And then the other thing that I recommend in the evening as well is set your future self up for success. So if you are getting up early in the morning and you are trying to get to the gym or you're trying to do that workout, have your workout clothes set out. Have your emotional support. I call it my emotional support water. Have that at the door. Have the keys at the door. Have the socks with the shoes at the door. Have your protein coffee or whatever you're doing, your little snack before, so that it's all ready, that there's no excuses.
Ready to go.
That you're ready to go.
Yep.
And there's something to be said about kind of easing your mind and creating peace when everything's ready the night before.
For sure.
You're not racing around trying to find all of your things so that you can get out the door. So those are the things that I always tell.
I think it helps you sleep better too, because then you're set up for the next day.
Yeah.
You're not stressed out about it. There's not less stress you're carrying to bed with you.
Absolutely,
right?
yeah. And then if I had to just choose one habit, just one, it would be movement after meals. Movement after meals. I've tracked so much continuous glucose data over the years, and that is the biggest longevity hack that I can bring to the table. And even better still, walking with friends or family after meals, or voicemailing your bestie after a meal while you're walking. Like, there's so many wonderful longevity hacks stacked into that beautiful 15-minute walk. And if you can't get outside because your son or your daughter wants to do Legos or they want you to work in the workbook, that's when you bring in the jump squats.
Yeah.
That's when you walk up and down your stairs.
Yeah.
But movement after meals, hands down, it can bring you back into metabolic homeostasis.
Yeah. So many powerful, seemingly simple things there, but people just don't do them.
I know.
Right? Mm-hmm. I mean, moving after meals is super simple. It's just, you just got to get used to doing it. And, going to bed at the same time every night. Just make it happen.
Make it happen.
Exactly.
Set an alarm.
Right.
I always tell people, set an alarm. And if you're a night owl, my husband's a night owl, I'm like, okay, we'll just start to move yourself down 15 minutes, but set an alarm and treat it like that's your $1 million meeting. That is when you get into bed. Just honor it. And I'll tell you, if sleep is an issue, which it is for 67% of midlife women, it is a massive percentage. And it is a driver of hyperinsulinemia. It is a driver of cardiometabolic issues. Sleep is such a cornerstone of everything that if you would just honor that sleep consistency, I'm telling you, it will change your life in less than 10 days.
Wow, that's awesome. Now, let's talk about a little bit, you're seeing your doctor, you're checking your markers, you're checking your hormone levels. Are there hormone treatments that are available during this time of sorry, I know that's a loaded question, but I have to put it out there. What can you do?
Yes, please. Yes, I love this question. Thank you so much for asking. I have an estradiol patch on right now, obviously, and I cycle oral micronized progesterone. And I will be honest, I was diagnosed with Hashimoto's thyroiditis years ago, and although my antibodies are in control, my thyroid got a little bit of a hit, so I do take thyroid medication, and so I'm fully transparent in my hormone protocol because there is so much that we can do to support women. Again, perimenopause is all about hormones. Can other factors be playing out at the same time? Absolutely. But we know what's really triggering those symptoms or exacerbating those symptoms or bringing them up for review is the hormones, is the erratic decline in hormones. And so progesterone is a beautiful option for women who are experiencing mood changes, anxiety, potentially even depression, and sleep issues. I'm a big believer of supporting you with hormones. Yeah. Progesterone is such a power player when it comes to just creating calm and peace. And it can really disrupt us, especially in that late luteal or that luteal phase. Yeah. That's half of our cycle. That's half of our life, where we could be losing that progesterone. And then, I find that symptoms do dictate estrogen. There's a lot of back and forth about when to bring on estrogen for perimenopause, because early peri, if progesterone is dropping, we can have unopposed estrogen. Yes. So that's where it becomes really important to track those symptoms and track your cycle. For me, even my follicular phase isn't what it used to be. Like, it's shifting. So that estradiol peak at day 11, she's not always peaking anymore for
Yeah.
me. I fall a little flat. And so for me, it's made a lot of sense to bring on estradiol. But for another woman, it may not be indicated for another couple of years. And so again, it's really driven by those symptoms, more so than it will be always driven by labs. Although I always say test, don't guess. Like, I want both. I want to take both into consideration, but I never want to withhold hormones because a woman's estrogen level is just barely above that okay normal, but she's feeling not normal.
Yeah. I'm seeing some devices out that are going to be launched pretty soon that you can test hormone levels at home.
Yes.
That's going to be a game changer.
It is going to be a game changer. Yeah, I'm really excited about that too.
Yeah, they can really day by day even direct your dosing and kind of modify what's happening, right?
Yeah, well, hormones are not a one-size-fits-all.
Right, absolutely.
Particularly in perimenopause. Darshan, I would say that I am a different woman every day, depending on what's going on with my hormones. Yeah. And, even my hormone protocol a year ago is different than it is today. Because that's the one thing I can guarantee for you in peri is that you are going to be changing.
Yeah.
Yeah.
That's the only guarantee is that things are not going to be the same the next day.
Exactly.
So can we dive a little bit into the forms of hormones that are available and how women should think about it? I know estrogen, for example, there's creams, there's patches, there's different kinds of patches. Can you tell us kind of how you think through that?
Absolutely. Yeah. One of the things that we've learned is that transdermal is really one of the safest ways, in terms of mitigating any cardiovascular concerns or particularly stroke. And so not taking it orally, we kind of mitigate even migraines with aura and things that we used to think were contraindicated. We're finding with transdermal application, it is amazing.
Wow.
I think for a lot of women, the patch is great. I know for me as a mom who holds my son a lot, creams and sprays on my inner arm, I'm going to esternize my child on accident, and so for a lot of women that are still holding kids and hugging kids, using a patch is a very viable option. And then it depends on the dosage. A lot of doctors are going to start with the lowest dose and just to kind of mitigate symptoms. But I'm a big fan of prevention as well. Estrogen is such a powerful preventative hormone for insulin sensitivity, for immune system modulation. Estrogen is the CEO of the brain, like in terms of even brain-related symptoms. And so I want to go a little bit past or looking past just mitigating hot flashes and night sweats and vaginal dryness. I want to be able to ensure that we're protecting your bone and your muscle and your metabolic health. And so that's always a consideration when it comes to HRT. So creams, usually those are compounded, creams and gels. Patches are going to be kind of FDA approved, what you're going to get from your typical doctor, and they're going to usually be covered by insurance.
Right.
When it comes to progesterone, usually the hormone or the application that I prefer is going to be oral micronized progesterone, especially for the brain-related symptoms and the sleep issues. But again, you have to know that prometrium is suspended in peanut oil and does have dyes. And so if you're sensitive, you may want to go the compounded route, especially if you're having severe sleep issues. An extended release progesterone that's compounded can be really beneficial for those 3 a.m. wake-ups. In terms of creams, there's a lot of controversy in terms of effectiveness. We know that progesterone molecules are pretty big, and so absorption can be a challenge. But some women will, I've seen some of my patients who have progesterone creams and serums. They will use them for anxiousness or feeling irritable during the day, but then they will step in with the oral micronized progesterone.
Got it.
In perimenopause, it makes a lot of sense to cycle progesterone, not necessarily use it continuously. So it's really a matter of figuring out what works best for you. If the sleep issues are so severe and you're in late perimenopause, is continuous use very much a viable option where you're taking it every single day? Absolutely, especially if you are sleeping better. So it's a matter of looking at all of these things, your symptoms, what application works for you, as you get started looking and testing, and also, having an honest conversation of what is actually feeling effective and then going from there. And so I find that it's constantly a tailoring of figuring out what works best.
Yeah.
So I hope I kind of covered a little bit.
No, that's fantastic. In fact, I think this is where a lot of women get really tripped up on the information that's out there. There's so many different forms. There's so many different controversies out there about using compounded versus not compounded. There's different patches. And let's talk about that, like the bias patch. How do you think about the estrogen forms?
I'm not a big fan of the biased
And
patch at
many
all.
doctors are not, but it's incredible that it's still being sold in massive quantities out there.
I'm not a fan of the estrone being a primary and just hoping that E2 is going to convert.
Yeah.
No. So no, I'm a big fan of estradiol as the primary. And not all patches are going to work for women. Some women are really big performance athletes and they just come right off. Depending on the different type of patch. I mean, we try one. You try one out and see what happens and see how you're doing. And if it's not working, then we try a different one and we play with dosage. I mean, it can really be. I don't say this in the sense that I want women to feel discouraged. I just want you to know that hopefully you're working with a provider or a practitioner who is willing to be open-minded and work with you during this time.
Yeah.
As a hormone practitioner myself and someone who's been working with women in perimenopause and menopause for almost 15 years, I'm still working out, what is best for me, what's the right dosage, when to take my progesterone. I know there's a lot of controversy around it only needs to be FDA approved. But then we think about testosterone. A lot of these doctors are like no compounded hormones, and yet they are recommending compounded testosterone because it's the only option, right? It's not FDA approved, and it's really, a lot of it's done off label. We're recommending off label testosterone cream, but it must be compounded, and so it's interesting the dialogue in the hormone space about what is appropriate or what's effective and what's not, and again, it's really about the patient.
Yeah.
Always.
And are you prescribing vaginal estrogen for most of your patients?
Yeah, I love vaginal estrogen. Like I'm rooting for the black box warning to get taken off. I think, almost 95% of women will have genital urinary symptoms of menopause.
Right.
They'll experience UTIs or they'll experience incontinence or vaginal dryness or vaginal atrophy or even painful intercourse, and that is not acceptable. And so I love that we have a local solution, and it should be a solution that every woman is offered. Even women who have had, potentially even cancer. Like it depends on what the situation is. Like every woman needs to be looked at. But it breaks my heart that so many women are being denied vaginal estrogen.
Why are they being denied?
I think it's fear.
Yeah.
It's a lot of fear.
Yeah.
We think that it's going to be systemic. We think it's going to cause cancer. And a lot of this has been debunked. And yet here we are. I don't think we're going to see... with as much noise and education as out there right now, at how long it will take to translate into bedside, into the office, it's going to take probably another, I would say, give or take 7 to 10 years.
And that's optimistic in my.
Yeah,
I was going to say, the everything in medicine right now, like by the time it gets taught in medical school and then taught in residency, so even if it's taught in medical school, when you go to residency and you're working for a doctor that has been trained prior and tells you no, then you unlearn everything that could potentially be good information. So I find it takes decades for the first, and I'm hoping in this new era that we're living in where people are getting more self-educated through listening to podcasts and reading books like yours, that it goes faster, but it's just so mind-blowing how long it takes for the medical establishment to change their mindset.
Yeah, no, it does take a long time. I am being a little bit optimistic given the noise that it's creating. And I have a whole chapter on HRT inside of the book because I want women to at least know the basics, to feel enough hormone literate that they can have the conversation.
That's the key.
That's really the key. So that you can ask your doctor, are you even prescribing HRT for women in perimenopause and menopause?
Exactly.
Do you feel comfortable prescribing? Because we have gone two decades of doctors not prescribing.
2 decades, right?
Yeah, and so you're talking about how long it's going to take. We're already 2 decades out, of not prescribing or doctors not feeling confident prescribing hormone replacement therapy. And so we have a lot of work in front of us to support women. And, again, it's a yes and. It's the hormones and it's the lifestyle. And I would never deny a woman hormones because the lifestyle isn't locked and loaded. I jokingly say that estrogen isn't going to lift the weights for you, but estrogen could get you in the gym.
Yeah.
Could get you that motivation to just get back in the gym again, or that testosterone could be the thing that has you motivated and confident and just feeling like yourself, not so flat, that you are like, you know what, I'm going to take that walk. I'm going to do those jump squats. I'm going to lift those weights. And I think that is such a big part of of this conversation is letting women have as many tools in the toolbox to help them feel like themselves again, so that they feel motivated and confident to start really attuning to themselves and taking care of themselves.
For sure. And then between vaginal estrogen and estrogen patch, being on vaginal estrogen doesn't replace the patch.
No, it does not.
And I think that's very, it's a very important point for people to hear, because I think sometimes they get the vaginal estrogen and they think,
I'm good.
I'm good. And I've seen that so many times.
Yeah, no, vaginal estrogen is localized. It's
only.
local only to the vaginal tissue, which is very important for your quality of life. But it's not going to protect your cardiovascular health. It's not going to protect your bones. It's not going to stop the hot flashes and night sweats from happening. It's not going to protect your brain and your muscles and your metabolic health. And so it's important to note that if you want that level of support, you are going to need a systemic estrogen.
Right. So you need both.
You need both. And for some women could just be on an estrogen patch or estrogen cream and be okay for a while. But I find that as we get older, we're going to need the vaginal estrogen too.
Yeah, need both, right? Yeah. And then let's talk about testosterone real quick and how that fits into the puzzle. When in the journey is testosterone an option?
And every doctor is different here. I'll be honest with you. I'm still looking a lot at the main reproductive hormones, and I'm also looking at testosterone as well. I mean, if I see low testosterone levels, I will consider bringing it on or recommend it. But I really do want to dial the estrogen and progesterone.
Right.
So I know that some women are on testosterone earlier, well before they're on progesterone and estrogen. I typically like to work with lifestyle recommendations to see if I can boost testosterone, especially if it's really like low way earlier than I would expect it to be. Like, I want to look at the lifestyle. I want to look at toxin load. I want to look at how much to-go food you're eating. What are your vitamin D levels? Are you moving your body or working out? Like, are there ways that we can increase that naturally? And if not, then I'll look at that as well.
Yeah. I think, that testosterone for women, first of all, what is considered low in your mind as far as
I would
the
say
level?
under 15.
Under 15, right? Okay, that's kind of what I used to, was under 15. I'm like, oh, this is really pretty low.
I'm like, and they've got the symptoms to match.
Yeah, exactly. Okay, great. And then I think, like you said, sometimes lifestyle interventions make all the difference. Just getting people moving can make all the difference there too. So I think as you're going through the perimenopause journey, and every woman is different, every doctor is different, but to your point, the testosterone can probably be managed with lifestyle interventions while you're figuring the estrogen, progesterone out.
And a lot of my patients don't necessarily want to go on testosterone therapy yet. They do want to try it. They want to try the lifestyle interventions first, because it's always there. Yeah, it's always on the table.
It's always on the table, right?
So we can always try in 3 months. We can retest levels and see how you're doing, and really just see how you're feeling, in terms of symptoms, and go from there. And so I want women to know that there's a lot that we can do, especially if you're in your 30s or your early 40s, and you're like, I don't know because I have so many patients, even friends I talk to, they're like, do I really have to get on testosterone? Because that's the thing that they're hearing a lot about, and not necessarily. Not to say that I don't love it. I think it can be really profound, and especially off-label.
Yeah. So, okay, let's talk about a woman's journey through hormone replacement therapy versus not having hormone replacement therapy. How does a woman who is on hormone replacement therapy with a good practitioner like yourself that is used to managing hormones, how does she kind of go through the next 5 years of perimenopause versus someone who doesn't?
I feel like the disparity is so great.
It's massive,
It's so massive. I always say that suffering is optional. You can decide how you want to feel. And women who go through perimenopause into early menopause with hormones, they feel more resilient. They feel more energized. Again, I'm watching biomarkers. I'm keeping an eye on all of this. They're still within that metabolically healthy range, and they feel more like themselves again. So that's a big part of it. As how are you feeling heading into menopause? But also when we look at DEXA scans, bone density looks looks well, and they're building lean muscle. This can be such a beautiful helper. Women who go through perimenopause into early menopause without HRT, I mean, for some, they can still be doing okay. And I think that is the greatest myth, is they're like, I feel fine. I feel good, and more so my concern is, well, how are you going to feel in your late 50s? How are you going to feel in your early 60s if we didn't have this hormone protection this entire decade in that window of opportunity? But I will say that even between my non-hormone users and my hormone users, that my hormone users do feel like they navigate it with a lot more ease and grace.
Yeah. And I want to talk about that woman that is fine being in perimenopause, doesn't feel a lot of symptoms. She's just like, I don't know what everyone's so worried about. I'm fine. Would you still recommend that woman be on some hormone replacement therapy?
I mean, from a preventative perspective, yes.
Yeah, I agree. I fully agree with you. And it's kind of a rhetorical question because I do see that sometimes that I have patient 42 years old, I think. I'm thinking about one particular patient right now who's a hard-charging CEO executive. She's like, I'm fine. I don't need all that stuff. And I'm like, well, wait a minute. Like, let's talk about prevention then. At least think about the preventative aspects here. And I think there's a case to be made.
How long does she want to be high charging?
Exactly.
Like, because that comes at a cost.
Yeah.
Like, you're burning, you're going to burn out at some point.
That's
and if
true.
you don't have the protective shield there to carry you through, she probably still has probably good hormone levels at that age, just know that level of charging ahead, high functioning, is going to come at a cost. At some point, it's going to catch up. And if we don't have the preventative tools in place.
I like what you said earlier, protective.
Protective.
Right.
It's your protective shield.
Right.
And that's why perimenopause is so destabilizing, because all of a sudden women have been doing it all.
Yeah.
And doing it all pretty effortlessly until we lose that protective shield.
Yeah.
And then all of a sudden it starts to fall apart.
And this is a mindset that practitioners need to get their head wrapped around. Like, hormone replacement therapy, in my mind, we're coming to a place where it's not just for symptoms.
No.
It's something that we really need to look at as a truly protective, preventative therapy for women.
Yes.
And it's kind of like, we have no problem slinging around Crestor at everyone that has a high cholesterol as a protective, I'm doing air quotes, protective mechanism.
Mm-hmm.
Yet, and that's a pharmaceutical agent. It's not even a bioidentical hormone that our body naturally makes since childhood.
Yeah, since puberty.
Since puberty, right, exactly. It's like, why are we so hesitant to give women hormones, but all the other pharmaceuticals for
fine.
prevention are okay?
Yeah. Well, are they even preventative?
Right.
I mean,
that's another argument.
That's another
right,
conversation.
Exactly. Right.
Yeah. I mean, the fear-mongering that has happened because of the Women's Health Initiative is just, oh my gosh, it's devastating that what has happened. That has set women back and set their longevity and their health span back. And I'm hoping that conversations like this, we really turn the tide on what women deserve in terms of preventative health. And even still, I mean, I can't tell you how many women come to me whose doctors, they're in their 60s and their doctors are taking them off their hormones.
I know.
Because they're at that age where they don't need them anymore. I just don't understand at all. I'm like, what? And you have to understand that within a year of you being off those hormones, you've lost, well, even less than that, you've lost all the protective benefit. All of it's gone. In 1 year
Yeah.
or less. And the women need to understand that. Then that conversation isn't happening. So whatever bone protection you had, whatever cardiovascular protection or brain protection you had, the moment you stop taking those hormones, you begin to lose that protection. So I always tell my patients, ride them until the wheels fall off, all the way to the end.
I love that. So, Mariza, what if you have a woman that comes to you, or there's a woman listening to this podcast who's 55 years old. She's in menopause, fully in menopause,
Yep.
but was never given the option of hormone replacement therapy. What should her next step be?
I would say first, let's take a look at your symptoms. Let's also take a look at your labs. I want to do, a cardiovascular workup. I just want to make sure she's good.
Yeah.
Even at 55, she's still within the window. Like, even at 65, she's still within the window. Like, there's no real
Is there a window?
contraindication. No, not really. I mean, I would say what we know from the Women's Health Initiative is after 20 years, we see a tiny risk for stroke and cardiovascular disease, but it's so slight. And again, this is with oral estrogen. This wasn't even with transdermal estrogen.
Yeah.
And so I would say that there really isn't a window. I still want to look at everything. I want to make sure that she's good to go, that she is a healthy host for hormones.
Right.
But at 55, particularly, depending on what her symptoms are, no, it's hormone replacement therapy, 100%.
I think even if you, unfortunately, we're seeing a doctor that was not going to even talk to you about it and has the Women's Health Initiative messaging of it's going to cause breast cancer, echoed out at you. And I think it's time to reevaluate and just look at the real science that we have now that shows that hormone replacement therapy is still very safe, and it should be something you go find a practitioner to
Absolutely.
evaluate you for.
As far as I'm concerned, she's on all systems go for HRT, and she does deserve that full workup so that she understands what's going on with her body. Right. A lot has changed even in those 5 years,
exactly.
When she went into menopause. So I want to make sure that she's clear on her cardiovascular status and her metabolic status. And even I'd love to, for her, it's not indicated, not until 65, but I'd love to see what her bone density is. Because at this point, she could have lost a lot of her bone by the time she's 55.
And no one should wait until they're 65 to check their bone density.
No,
you can get a DEXA scan on your own. You can just Google DEXA scan near me.
Yeah, exactly.
And you can find one. It's $50 and just go get it done and know where your bone density is.
And I would say 40 years old is when I want that done.
Yeah, exactly. And let's talk about as we get older. So the 55-year-old woman, no hormone replacement therapy, up to 65, you said, is probably still okay. And even after, okay, if someone is on hormones or hasn't had hormones, is there a way to kind of, I think the biggest negative aspect of hormone replacement therapy that people worry about is cancer, right? Specifically breast cancer. Is that correct?
That's correct.
Okay.
Yeah.
And so maybe, like you said, with oral estrogen, there might be a slightly increased risk later on. But is there a way for women to be proactively screening and making sure that this is not an issue and they can still do hormone replacement therapy?
In terms of their cardiovascular health and their breast health?
Exactly.
Yeah, absolutely. I think we should be screening as early as our 40s for both. Yep. And I think if you have a good primary doctor, there are screening for, I had a breast cancer scare last year. And it was fine. But I'm really grateful that, I'm looking at that. When I go to my primary doctor, who's a good friend, we're looking at colon cancer and we're looking at cervical cancer and we're looking at breast cancer. That is their list. Yes. And then I've got my list.
Exactly. I love it. What's your list add to that?
I want all the biomarkers. Yeah. I usually like to do an ultrasound on my thyroid every 5 years or so just to make sure we're good there. And I'm, anything that's coming up for me. But mostly I'm fighting for the biomarkers, and then, and also a cardiovascular referral so that I'm looking in more depth, especially with the health history of my family.
Yeah. I love this concept of that they have a list and then you can have your own separate list now. And you really, one of the things I advocate at Next Health is obviously, number one, checking your biomarkers much more frequently. We like to do them every 3 to 4 months.
And I love that.
Yeah.
That is so proactive.
So proactive.
If I could get 3 to 4 month data, I love it, but at least twice a year.
Yeah. And look, that amount of data is not right for everybody, but if you're someone that is data-driven and is good about learning about your health, I think it can be very helpful. But the cancer list especially, the cancer list has not moved in decades. And there's so much incredible technology out there now to look for cancer much earlier and less invasively. And there's an argument to be made we should be doing everything much sooner as well,
always.
Because people are getting cancer a lot younger as well. Can I dive into a little bit about how you think about breast cancer screening and what's MRI versus mammogram versus other modalities? What are your thoughts around that?
That's a good question. Obviously the gold standard for us is going to be the mammogram. I love looking at, I had my MRI done earlier this year, and I think there's no one diagnostic tool that I think is better or more superior than the other. And I think whether it's even thermography, if you want to just preventatively just looking at that, and maybe it can indicate if there's inflammation or anything going on, particularly in the breast tissue. But I would say MRI if you can afford it. Again, I want to make sure that it's cost available as well. Ultrasound, mammogram, just even self-screenings, I think can be really helpful every single month. And then I would be also looking at, there's other technology out there as well that just isn't as readily available right now. So but those would be my recommendations.
Yeah.
I'm probably going to do, especially with my breast cancer scare, I will probably do MRI every couple of years, if not every year.
Yeah. And I think, to your point, every woman is so different and you have to go based on what is the density of your breasts? Are you on hormone replacement therapy or not? There's a lot of, and hormone replacement therapy could be argued to be protective against having cancer as well.
Yes, it can.
So I think it's a positive to be in hormone replacement therapy. But I used to be a breast surgeon. I did breast cancer surgery and breast reconstruction. And I just remember thinking all the time, like, why are we finding these cancers so late, And I think there's something to be said that we really need to look at on an N of one basis. How do we update our cancer screening protocol for each individual woman and their particular risk versus like this population-based, we can only do mammograms on everybody because that's what the population can afford to do, And I think if you're a woman listening to this, really look into MRIs. I think MRIs are becoming more available. They are still very expensive, but you can get a full body MRI and look at your breasts in that as well.
For like $400 to $500 now at this point.
It's getting much less.
Much cheaper.
Much more affordable. And I would argue that, diagnosing a cancer at stage 1 is much better than finding it at stage 3 or 4. That's really expensive.
Yeah, it's very expensive. And it's not only financially expensive, but it is quality of life.
Absolutely.
I think a lot of us, again, as we talked about in the beginning, is that we think we're just got to tough it out and we need to survive this. And that is so far from the truth. Like, you get to have a gold standard of care. You get to have a team that supports you. You get to have the lifestyle strategies that move the needle for you in a meaningful way so that you are thriving through this. And that those signals, those symptoms, what you're dealing with, if anything, it is just a beautiful reminder. It's your body's way of telling you that it's time for a new level of support and care.
Great. What about mindset shift number 2?
Okay, I would say mindset number 2 is that don't fear HRT, don't fear the longevity strategies. Like, you deserve all the tools in the toolbox, and you deserve to find a provider and a practitioner who is willing to work with you on the hormone replacement journey.
Yeah, I love that. Okay, so number 3, I want to add, don't think that hormone replacement therapy is going to lead to breast cancer. I think that's a major fear that has been ingrained in people's brains the last couple of decades from the Women's Health Initiative. And I think we have preventative strategies, which is hormone replacement therapy can be preventative. And we have great screening, and just accelerate your screening maybe.
Oh, right? Absolutely. Yeah, and earlier. Yeah, accelerate your screening and earlier. I mean, I think it's about you get to be proactive about your health. When you were talking about becoming the CEO of your health, I always say no one's coming to save us. And so often for women, you're the one taking your kids to the doctor's office. You're the one checking on your husband's or your partner's biomarkers. You are really the epicenter of everybody else's health. Well, guess what? You're the epicenter of your health too. Yes. And so the more that you can take ownership of that, like, that is a superpower. Right. That gives you agency.
Exactly. Okay. Number 4. What you do number 4?
Okay. Number 4. I say number 4. I'm trying to think about all the things that I say in mindset. That even one shift, one habit shift, whether it's a conversation about HRT, or it is moving after a meal, or it's sleep consistency, or it's tracking your blood glucose so that you're getting that data. That one shift, it doesn't have to be an overhaul. It doesn't have to be full burnout mode. Like, it doesn't have to be perfection. One shift can make all the difference.
Yeah, absolutely. And also on that point, getting into a place, like you mentioned a lot earlier in this conversation, where you have 45 minutes to yourself every morning to have a routine where you can do some of these things. And the benefits of that will stack up over time. Right?
Compounding interest.
Exactly. And I will say number 5 on my end is also just becoming the CEO of your own health and following your own biomarkers and learning what are the important ones, why they're important, how you can affect them, and what's the optimal range, not just the disease range.
Absolutely. And that information is available.
Yes.
Like, it's available in the book. It's available on your Instagram, on my Instagram. Like, someone asked me, what are your 6 top biomarkers that you want people to know, right? And these are these numbers, they give you power. And the beautiful thing is when you're tracking them every 3 to 4 months, you can move those numbers back into optimal range. I want people to know that let's say a triglyceride level of 185 milligrams per deciliter, that doesn't have to be your normal. You can get it back down under 80 milligrams per deciliter. I want you to know that there's so much power in that knowledge. And the more that you understand your biometrics and your lab numbers, that's when you get to move the needle. Yeah. Like, I just got my labs back yesterday, and I was just tickled when my fasting insulin was a 4.
Ooh, that's amazing. Yeah.
And I was so tickled. My fasting blood glucose was 80.
Beautiful.
And my lipoprotein little a was 40. I was just, you should have seen the happy dance I was doing,
It's all good.
You get to see this. Yeah, you get to be like, okay, what I'm doing is working. What I've done in the last 90 days is working. And I'm going to keep doubling down on that. If you're not loving the biomarkers, you can be like, okay, what was the last 90 days like? What can shift? And that's why I love the continuous glucose monitors as well, because in real time, you can influence your cellular energy.
Yeah.
That's powerful.
Yeah, I love that. This has been such an incredible conversation. This book is coming out soon.
Yes,
right?
it is.
The Perimenopause Revolution.
Yes.
Can it be pre-ordered?
It can be pre-ordered.
Okay,
This
great.
is my movement, my mission, the rally cry for women to feel so good in their bodies. Yes, I have amazing pre-order bonuses, including exercise snack videos, intermediate and beginner workout videos. I've got lab ranges, how to track your cycle and your symptoms, so your perimenopause tracker, metabolically healthy meals, meal plans. So while you're waiting for this book, I give it all to you.
Oh, so you can pre-order it
and
you
get
this.
all those bonuses.
Where can we pre-order it?
drmariza.com/book. That'll take you to the bonus page, and you can buy it anywhere books are sold. Amazon. I just finished the audio version, so it'll be available on audio as well. I'm so excited for that because I'm a big audio. I did.
Oh, wow.
Yeah,
Fantastic.
I was in the studio for 4 days. Yes.
Yeah. And for anyone listening and not watching this, there is a massive smile on your face while you're talking about this. You can feel the passion as you talk about it. And so I'm sure that's going to come out in the audiobook too.
Yes, I was very, it's an undertaking, but it's such a beautiful honor to get to read your own book.
Oh, for sure.
And I'm so excited because I, as a busy mama, I listen to a lot of my content on Audible and on podcasts. And that's where I get, and then I like having both. I like having the audiobook and I like having the hardcover.
Yeah,
I like
too.
having both. Yeah.
I do the same thing. I have both. Well, this was a fantastic convo. Thank you so much for this. It was such an honor to have you on, and I learned so much today.
Thank you for having me.
Yeah. Where else can people find you? Do you have social media? Yep.
I'm so excited. I just invited you to come onto my show, Energized with Dr. Mariza. And this is really, the conversation we just had, we can just translate it over to Energized. At Dr. Mariza, DrMariza on Instagram, where you'll find a lot of levity around perimenopause and metabolic health. Just a lot of humor, because sometimes we need a little bit of that to get through this transition. And drmariza.com is where you'll find the book and all the other things.
I love it.
Yeah.
Thank you so much.
Thank you.